Hello, everyone. My name is Evelyn Haymore, and I'm here to talk to you important topics in relation to taking care of our patients in MSICU. So, basically, what I'm focusing today is basically the whole thing about cardiac output. What we want to know about cardiac output, what, the why, the when, and the how. And this is going to be talked about in my whole lecture pertaining to cardiac output. I would like to review with you certain basic principles because knowing these basic principles, it's easier for you to be able to relate what the topic will be all about. So let's talk about a little bit about circulatory system, in the heart per se. And the reason being, I would want you to know the importance of especially the valves that are involved in circulatory system. So first off, let's trace where the blood is going back to the heart. Okay? And as you know, this is blood coming from the lower portion, goes back to the heart via inferior vena cava. Excellent. So the blood coming from the upper part goes back to the heart via beautiful. So now remember, all this blood coming into the heart are unoxygenated blood, okay? So we start from there, we will deal with the valves involved because I want you to realize the importance of each one. So as we said, blood flows back to the heart, into the right atrium, passes to what kind of valve is this? Tricuspid valve. Very good, Teresa. You know your thing. And so from here, the blood flows to where? Goes where? Pulmonary artery. Via what valve? Why is it called artery where it carries unoxygenated blood? Tiffany. Pardon?
Because it's away from the heart.
Very good. So this is actually the exception to the rule, okay? It's artery and yet it carries unoxygenated blood because it's going away from the heart, all right? And so from here it goes to what we call important part of the body is
Lungs.
the lungs. So from here now, the blood is being oxygenated, right? Now it's time to go back to the heart via what? Pulmonary veins. And how many do you have?
4.
Very good. So there are 4 pulmonic veins, 1 to each lung, okay? And returning to the left atrium, right? In the form of oxygenated blood via what valve?
The mitral valve.
Mitral or bicuspid. So they are synonymous, okay? And then from here, it goes to where? To? Come on.
Aorta.
Aorta
Via the aortic valve.
via aortic valve. Okay, so these are the 4 valves. Now let's talk a little bit about ventricular systole and ventricular diastole because you have to know this when you have to know your cardiac output. So what happens on these valves on ventricular systole? When we talk about systole, ventricles, systole, boom, both ways. So what happens to these valves on ventricular systole? What happens to the tricuspid and the mitral?
Close.
Close, very good. The reason you want them close, you want the whole blood to be pumped out with no problem. Otherwise, if you have problem with the valves, you will have regurgitation, that full cardiac output is being dispensed, okay? So very good. So, and the other ones should open, right?
Mm-hmm.
So at the same token on ventricular diastole, where you call it ventricular filling, or they say relaxation, the heart never relaxes anyway. So that is when ventricular filling, so that you want this and this to open. At the same token, you want the aortic and the pulmonic valves closed. So there's no leaking and there is no regurgitation. Very good. So now we got the picture. So let's move on towards cardiac output. Let's talk a little bit about blood pressure. What makes up a cardiac output? And there are three important things that make it up. One of them is, of course, you want a pumping action, and that pumping part is your heart. You have to have a good pump, okay, in order to make up a blood pressure. And on top of that, you need a very important thing, which is volume, because without volume, there's nothing to pump the heart with, right? And of course, the third one is resistance, because if you're just gonna pump it out, and you have to have some resistance to keep the blood pressure or the pressure, going, so you need that resistance. In other words, to summarize, you have to have heart, volume, resistance. Now again, remember these words because this is related when we talk to cardiac output, okay? So knowing that, I know here in MSICU, when we do take blood pressure, we pay particular attention to the MAP. And what is MAP? MAP mean arterial pressure. And what does that indicate? What's the importance of MAP? Actually, when we talk about the MAP, you are talking about arterial blood supply. That is enough to meet the demands of the tissues. And that is MAP. So adequate oxygenated blood needed to keep the tissues alive, okay? And what is the formula for the MAP when we talk about MAP?
2/3 diastolic.
Yeah, so systolic
Systolic.
plus diastolic times 2 divided by 3 is your MAP. Yes? So let's get an example. We have 100. And let's say the diastolic is 60. Multiplied by 2 divided by 3. So this will be 120 plus 100, right? 220 divided by 3 because 1, 2, 3 makes, do your math. So this is your map, okay? So knowing your map now, again, for us here, we normally, based on the map, and it's gotta be the normal of which should be kept over 60 in order to meet that tissue demands, okay? So I want you to remember that. In other words, the viability and the function of the tissues is dependent upon the adequacy of the supply, oxygenated supply. As you know, my husband teaches or taught economics, and he's an economist, and he always talks about supply and demand, the law of economics. And I said, wait a minute, I think I can apply that to the body, supply and demand, the law of the body, supply and demand, meaning you should have enough supply in order to meet the demands. So it both ways. It really important that these two are related to each other. The importance of supply and demand, of course, is dependent again on three factors. Again, we go back to the effectiveness of the pumping, action of the heart, and then we should have a good hemoglobin and hematocrit, and of course, with that, we should have a good oxygenation. So those are very important things to think about when we talk about cardiac output. So cardiac output is really a measure of the heart as a pump in general. Cardiac output is a product of what? Heart rate and stroke volume. But what does that mean? What does in relation to cardiac output? So I basically devised it myself actually to be easier to remember. We talk about electromechanical system in the body. And for me, heart rate is categorized as your electrical part. You have to have electricity in order to have the mechanical part of it. Electrical meaning your EKG, your sinus road, your pathways, electrical pathways, that is being regulated by your nervous system. So that is the electrical part. You know about this. Now we will talk about the stroke volume. What are the determinants of stroke volume? Let's dissect each one. The first one is preload. The second is afterload. And the third is contractility. These are the determinants of stroke volume. You need all of these three to have a good stroke volume. If it's only one, it's not going to work. So you have to have a preload, afterload, and contractility. So preload, let's talk a little bit about preload. So what is basically preload? Preload, you talk about volume. Okay? Now, this is your tissue right here. This is your body. This is your vessels, tissues, or vascular beds. Okay? All these three, I sum it up here. When I talk about preload, I told you it's the volume. Volume meaning, amount of blood returning to the heart. Again, another scenario in this preload is, the study that is made by doctors Frank and Starling. Frank being, they said he's German, and the other one is European. So actually, they made a study about the preload before, and they found out that the preload is dependent upon the muscle, the muscle of the heart to expand and the fiber to lengthen. So the more you expand, the more you lengthen, the more volume is accommodated in the ventricles. So a good example is if you put a balloon, empty balloon in a faucet. And then you open the faucet, water fills up the balloon expands. The same thing in the heart. The more water you put, the more the balloon expands, the more volume it can accommodate. So this is the same theory on the preload. And again, how do you know that? We will talk about this one later. We'll talk about the CVP and the wage in order to do or check the preload. Another example is the bow and arrow. The more you stretch the bow, the farther the arrow will go. So it's because of the force, because of the elasticity that it functions better. Let's talk a little about atrial kick, because this is also important, okay? Now, atrial kick, as you know, in our post-op, surgeries, sometimes you see a pacemaker being connected to the atrial wires. It's because of the atrial kick. However, there are two phases of atrial systole. Now, when I talk about atrial systole, what's happening is the ventricular filling, right? Because you're pressing the atria, pushing it to go down to the ventricles. However, when the ventricular filling takes place, there are two phases, as I said, with atrial systole. The first phase is the passive opening of the tricuspid and the mitral valve. Only the passive opening. And what happens on this, 75% of this blood goes to the ventricles. There's still remaining 25% in the atria. So that is your phase 1. And phase 2 is basically the actual atrial systole, where the atria contract. The remaining 25% is being pushed down so that you can attain as much as, we hope 100% of atrial systole. So those are the two phases of atrial systole. Second, we talk about afterload. What is exactly, this is your preload, which is volume. And again, it depends on the condition of your vessels, tissues, and vascular system. That, the returning volume will be dependent on this. So that is your preload. Afterload is here. Afterload is the resistance. You have to have, as I said, like blood pressure, you have to have a resistance in order for the blood pressure, the cardiac output, to keep it in a good amount of cardiac output. And again, resistance will depend upon how the tissues are. Are they clamped? Are they vasodilated? Are they dry? All these conditions will be dependent on the resistance characteristics of this afterload. So it's actually the pressure, It's the pressure that the ventricles have to overcome to ejection that is created by the arterial vessels and pulmonic system. So the next thing, a good example for this is, let's say there is a heavy or very windy condition outside and you're trying to close your door. And you're trying, and then the wind is trying to stop you. So you are meeting resistance. Exactly is true with this. So the resistance that the heart has to meet in order to get the blood going. And a good example also on the afterload, because this is now the ventricular pushing the blood out. If you have aortic stenosis, so that is resistance right there. So the heart is trying to pump it out, but the aorta is resisting it because of the stenosis. So this is another example of the afterload. Now the next is the contractility, or we call it force or power. And this is your contractility. The heart now is functioning. The force. So cases like, myocardial infarctions, cardiomyopathy, this type of thing, or arrhythmia per se, this really gives a weak muscle for the heart to pump the blood up for contraction wise. Okay? So we need to have a good force to get this volume out for the afterload. So that is basically your preload, afterload contractility that is important in playing a role in your cardiac output. And as I said, with the heart rate electrical, like for example, atrial fib, where cardiac output diminishes because not all of the R, your R wave is being pushed through, is being conducted through. So that limits, again, the cardiac output. So contractility, as I said, the force, or we call it the ionotropic part of the heart. Like you hear about ionotropic. So that's basically what the force is, or in the contractility. So knowing all this, knowing your cardiac output, now how do we distinguish? How do we know all about this? And that's why we will talk about Swan-Ganz catheter shortly. And what the Swan-Ganz catheter will tell you, will give you all those information. And what's the importance of Swan-Ganz is that, doctors will say, let's go, because they don't know what's going on with the patient, right? So the doctor will say, let's insert Swan-Ganz. So why are we inserting Swan-Ganz then? Number one, for doctors, for us to get a diagnosis. If they're not sure what's going on, go put Swan-Ganz, so you will find what's going on, do a diagnosis, and once diagnosis is established, then you can do the therapy. And when the therapy is done or intervened, then you can modify, and then you can. What basically is hemodynamics. So hemodynamics, to dissect Hem is blood, right? And dynamus, these are all Latin words. And dynamus is movement. So what we basically dealing with in this topic is the movement of blood. Hemodynamics. And this is now what we're going to talk about when we talk about Swan-Ganz catheter. Okay, so we have discussed a lot, and now I want to know what questions do you have for me? Okay, Tiffany, what do you have?
You talked about aortic stenosis for afterload.
Mm-hmm.
What other things can affect afterload in our patients?
Okay, now remember when I talked about afterload, I talked about resistance, correct? So we have to think about what resistance can the heart meet, and look, with this, try to think, the pulmonary system. You talk about the periphery, and so when we talk about that, how tight they are, how dilated they are, and this will affect your afterload basically. And as you mentioned, you talk about aortic stenosis, and because that can also impede the blood coming out from the ventricles. And another thing is, of course, you go back to the tricuspid and the mitral. Make sure that it's tightly, closing, so that there's no regurgitation. That's another thing you have to think about. So all this can affect your afterload, the resistance that the heart will meet when they pushed out this blood from the ventricles. Does that answer your question? Good. Oh, you have also a question, but that was an excellent question, by the way. Okay.
Are there any things that can affect the preload?
Yes, we talk about what is the component in the preload. And remember, I talked to you about the volume. When we talk about preload, it's the volume content. So anything that impedes the volume going into your right atrium can impede your, or it can decrease the cardiac output or the ventricular filling. And one of them is, of course, how well the patient is, what you call the vessels are hydrated. That's one. And how is the map? We talk about the map, the blood pressure. And again, valves can be involved with this, your tricuspid and the mitral. We want to have those working valves in order for the blood to go down to the ventricles. Does that answer your question?